Yes. Mhm. Good. Mrs. Lowe is still.
Good afternoon.
Mhm.
Good afternoon, everyone. On behalf of the Tallahassee chapter of 100 Black Men and our president, Dr. Marvin Henderson, we just want to welcome you to this quite relevant and important workshop discussion presentation. I told Dr. Hill I just wanted to mention a little bit about where I am. Even though I'm retired, I still work with the College of Agriculture and Food Science at FAMU. And they allow me uh, to interact with the students. So I provide hands-on training for our pre-vet students. And I'm here on the farm doing a class with them. So if I step away, it's because I have to take care of my students here at FAMU. But we are indeed privileged and honored to have Dr. Hill and Dr. Sneed and her team to come and talk to us about this important issue, especially for as it pertains to our Black community. And I can tell you that I have taken my vaccines, and I'm alive and well. And I feel so comfortable about it that next week I'm going to get on a plane and I'm going to go to Minnesota and visit my grandkids, and I'm going to feel good about it. So I would say up front, it's something that we have to do for ourselves and for our families. So, Dr. Hill, I do want to say again how much I appreciate the association and the connection that we've made with each other. And I look forward to continuing to work with you and Dr. Sneed and your team as we go forward. So without further ado, let me say again, welcome to everyone. And I'll just turn it over to Dr. Hill. Dr. Hill, you take it from here. Thank you, ma'am.
Well, thank you, Dr. Mobley, for that introduction. And we'd like to also acknowledge Dr. Marvin Henderson, the president of the 100 Black Men. And thank you again for yielding and allowing us to collaborate and work with your group. And we appreciate all the hard work that you all are doing. And it's certainly admirable, Dr. Mobley, that you are still engaged with students, and definitely makes me feel good to know that you're contributing, at least at my alma mater. It is, again, another pleasure to be here this afternoon and introduce the Tenacia College of Pharmacy's community engagement arm by the name of We Care, which stands for Work Group Enhancing Community Advocacy and Research Engagement. And this is the brainchild of our founding dean, Dr. Kevin Sneed, who's also Senior Vice President for USF Health, a pharmacist like myself, as well as certainly a very, very becomingly popular gentleman in the Tampa Bay community. Dr. Sneed actually formed We Care over a decade ago, consequent to working with the Health Equity Center as a part of a P20 grant that incorporated diversity and health disparity work with Moffitt and the College of Public Health at University of South Florida. And We Care is the only living evidence of that work. But We Care also represents an expansion of the mission of the Equity Center by working to actually bridge the understanding of the community with the the research community at the university and making sure that everyone really has a respect for the opportunities and the processes associated with research, and understanding why there's a need for us to have diverse representation in products and in the use of devices before they actually hit the market. And so we have collectively worked with all kinds of diverse groups to include African Americans, Hispanics and Latinos, West Indians, and individuals from our Caribbean brothers and sisters from the continent. And so as the pandemic has arisen, we included COVID and COVID care, and particularly the COVID vaccine, as a part of our educational mission. So it indeed is a pleasure to be here with you. But We Care can't operate without the help of community support. And so as I'm serving, or have the pleasure of serving as the project director with We Care, we also have the person of Dr. Deborah Austin, who's with us today, representing Reach Up, which is an example of a community-based organization that actually has positioned itself for over 20 plus years in the Tampa Bay community as a spinoff from work in the College of Public Health and the Child Center to actually foster the needs for maternal and child health. And so we are so excited because Dr. Austin has allowed us to have a greater reach in the community. And then we have other individuals who aren't with us this afternoon, Mr. Hiram Green and Mrs. Christy Andre, who also assist in supporting other avenues of our community outreach, education, and research advocacy. And so this afternoon, what we hope to do is kind of dispel some of the myths that have been circulating as it relates to the pandemic. As we have embarked since May on doing these workshops, we have heard all kinds of things. People are under the impression that if you get the vaccine, you're going to be getting the infection, or that your fertility will be affected, or that this is a genocide attempt. We've also heard that we're going to damage our DNA. We've heard things, as it relates to the infection, that the infection itself doesn't exist. And so today you get a chance to hear our dean as he explains a little bit more and helps us dispel a lot of these myths. And so we encourage you to ask questions and utilize the chat, and both Dr. Austin and myself and Dr. Mobley will make sure that we address any pressing questions that you may have. We do understand and respect everyone has individual choice and opinions about the matter, but we like to impart everyone with enough knowledge so they can make an intelligent decision. So by a show of hands, I'd like for you all, if you could, to turn on your cameras just for a moment. And for those of you that have been vaccinated, maybe raise your hand so that we can appreciate those of you that have been vaccinated. And the reason I wanted to do that is here in the Tampa Bay community, some of the work that We Care has done has been supporting vaccination events in the community, actually facilitating them at churches and the university and other community centers to really make sure that it's available to those that the governor has deemed appropriate to receive it. And we are proud to say that we've been successful with the help again of Reach Up and other entities, that all of these civic and social and faith-based communities that we've been trying to share our educational message with, we've collectively probably created an opportunity for maybe 2,400, almost 3,000 individuals in the Tampa Bay community. So we are really proud, but that our team ourselves has made sure that we are not just coming to you with the message, but that we too have all gotten vaccinated. So Dr. Sneed today is going to let you appreciate that. Again, he's a pharmacist, but he also has an undergraduate degree in microbiology with a specialty in immunology. And he's probably one of the best read pharmacists you'll come across, having read probably close to, if not more than 350 articles in the scientific literature related to all things pertaining to the pandemic. Dr. Sneed also has been continuously working as a clinician throughout his academic his lab jacket on today, but most times he's in clinic seeing patients. And so he has been working extremely hard during the pandemic. If he's not doing workshops, he's helping set up vaccination events, or he's actually seeing patients in his clinics. And he works with individuals with chronic disorders, diabetes, metabolic syndrome, which is one of his specialty areas, hypertension and the like. So we are just so fortunate that at the Tanasia College of Pharmacy, we have a dean both with intellect, insight, and most of all, vision. But what I appreciate the most about him is that he has passion for the work that he does. So it's so nice to see familiar faces like Mr. Glenn Brown. And certainly we have enjoyed working with Ray Mobley and Dr. Mobley and Dr. Hernandez, and they have created opportunities for us to share our experiences and insights with the Tallahassee community. We have some of our newer partners. We see Mr. David O'Neill on and Dr. Kong as well. So just so excited about seeing all of you. And if I'm not mistaken, I thought I saw Christy Andre, who's another member of our team. So I did want to acknowledge her because certainly she has made a lot of the work that we've been able to do with We Care possible. She was a part of the early days of We Care, helping Dr. Sneed get everything set up for our research advisory committees and a lot of our marketing materials, as well as recruiting student help and all things. So we are just so grateful to have her here today as well. So without further ado, I'll stop talking and allow Dr. Sneed to give us about 20 or 30 minutes of really, really bona fide solid knowledge about the COVID pandemic and where we are with the vaccines. Certainly we know the J&J vaccine just recently came out. And so there's probably a lot of questions that you all have related to that and other vaccines and what's to come. But I'm sure that you'll enjoy his insights. And again, I encourage you to write any questions that you have in the chat, and we will address them as best we can. So Dr. Sneed, I'd like to introduce you. And for those that don't know you, I'll introduce you to him. And for others, I'll represent him to you. Dr. Sneed.
But Dr. Hill, thank you. Dr. Hill, thank you very much for that very kind introduction. And again, wanted to acknowledge all of our teammates that we have here, Dr. Austin, Ms. Christy Andre, of course yourself, and our other teammate that couldn't be here today with us, Mr. Hiram Green. I'm going to ask everyone to buckle up and hold on tight. I'm going to try and get through this presentation rather quickly, and we really want to spend time on the end having a question and answer session. That's the time to really, really dispel many of the, a lot of the misinformation that may be out there, or just even your own curiosity. And I'm hoping that the presentation I give to you will unlock some curiosity, and you have plenty of questions for us. And the other component I would really like to encourage all of you to understand as we're going through everything we're talking about here from a standpoint, even though it's built for the community, everything I will share with you will be evidence-based. And is hopefully you can find readily somewhere, if not on the CDC website and other publications that we can provide for you. So with that, let me just share my screen here. Okay, and we're gonna go ahead and get started. The first thing I would like to do is really just kind of start with a quick video about We Care, narrated by our very own Dr. Hill.
So, well, why do we care? Why we care? Why this program? We want to improve health outcomes.
The collaboration between USF Health's Tanasia College of Pharmacy's We Care program and Reach Up Incorporated aims to bridge the gap between underserved communities and access to care. We Care's mission is to increase the representation of diverse populations in clinical research. It starts with rebuilding trust between academic and clinical institutions through educating and empowering the community, and then providing research opportunities along with protection and advocacy for the participants.
They want to hear the story from folks who have been through a clinical trial.
You have to share all of that information with everybody.
So take the opportunity to have a better quality of life in our communities. Join us.
Okay, let's go ahead and get started. We'll just start off really just talking about the coronavirus overall. The coronavirus is really a family of viruses, and I'll kind of allude to the fact that the current coronavirus really is far different than the ones that we've probably commonly experienced before now. Many of you may have had the common cold or the flu in the past, and you may have thought it was caused by a rhinovirus or even the influenza virus. But it may have been a coronavirus. About 10% of individuals that wind up wind up having flu or common cold symptoms are probably were infected by a coronavirus. Back in about 2002, we had the original SARS. Now we have to refer to it as SARS-CoV-1. SARS-CoV-1. It only infected about 8,100 people worldwide, but it was actually pretty lethal. Because over 800 people died from it. And so we had over a 10% death rate from that particular virus at that time. That evolved, and then we had the MERS, that you may have heard of, and back in 2012, 10 years after that. And then we moved on to now the SARS-CoV-2, or back in 2019, what we were calling the novel coronavirus. Now, what I'm showing here is really the fact that we've had these pandemics that occurred first from a 10-year period, then it went down to 7 years. And so it's not unthinkable to think that we may actually have another pandemic within a 4 or 5 year period. And so I think the experience of what we're going through right now and everything that we're learning hopefully will prepare us for that time. Now, for many people that keep wondering and questioning whether or not this is a real virus, is it real? Is it a hoax? Well, what I'm showing you here is an actual electron microscopy photograph that came from the labs of Dr. Fauci up at the NIH. Now they've colored in the photograph just for so that we can visualize it better. But the green portion you see here is a single cell, and the yellow dots on there are the actual virus. And so when we're talking about millions and millions and millions of copies of this particular virus potentially being in your body, we begin to understand very quickly how that can occur. I'm going to show you a quick video here, again, just to kind of explain a little bit more about the virus, how it gets into your body, and then I'll share more commentary on the back end. Oops.
In a world where millions of lives are under threat due to COVID-19, it is of vital importance to gain a better understanding of how the virus actually works in search of a cure. The surface of the virus particle is covered with approximately 100 spike proteins. They always come in groups of 3, in which the proteins are intertwined. Each individual protein consists of 2 parts: a globular head called S1 and a stalk-like structure called S2. One of the 3 heads is slightly bent, enabling it to connect to the so-called ACE2 receptor on a human cell. Once the connection between the virus and the receptor has been established, the human body activates the TMPRSS2 enzyme. This is a protein-cutting enzyme that proceeds to cut off the head of the spike protein. This causes a change in the structure of the virus. The S2 protein now grows longer, penetrating the human cell. The protein then retracts again, bringing the membranes of the virus and the cell very close to one another. At this point, the virus can enter the cell through a process of endocytosis. It engulfs the cell with its membrane. The virus has successfully invaded the cell and can now start to multiply, ready to overrun the system. However, we have strong defense mechanisms that try to prevent this from happening at all costs. Scientists recently discovered how our antibodies react. It's actually a very simple process. Our antibodies bind to the spike head, or S1, thereby preventing it from connecting with the ACE2 receptor and stopping the virus from spreading. Understanding exactly how this process takes place is key to the rapid development of a vaccine, making it an essential part of our ongoing fight against this global public health crisis.
So on the video there, and we've seen many of the photographs on TV of the red spikes that occur on the outside of the coronavirus. That's the spike protein. I want you to think of that as being very much like Velcro. And the ACE2 receptor that was shown there in the video is very important to understand. Every human being has that particular receptor in our body. And this particular form of this coronavirus is now programmed to attach onto that ACE2 receptor. And that's how it can gain entry into many of the cells in our body. And so if we had a piece of Velcro and you put that onto your favorite sweater, your wool sweater, and tried to pull it off, you know how sticky that would be. And that's the very same relationship we have between the coronavirus and the ACE2 receptor in our body. Now, it's very important to understand, as I tell many people when I'm giving this presentation, hopefully, if you don't remember anything else I tell you, I want you to remember and recall the fact that the actual virus, the true virus that's out in the community and spreading around the world, has a little strand of RNA right on the inside of it, and shown here encircled by the red circle. It's very important to understand that not one single version of any of the vaccines has anything live in it, and it does not transfer that little RNA strand into your body. That RNA strand, once it gets into your cell, is now responsible for gathering a bunch of proteins and repackaging itself so that it can reproduce itself. But it's not just reproducing one, it's reproducing thousands and maybe even millions of copies that potentially can overrun your immune system and your body. So I really wanted to show people and really help people understand about this little RNA strand, because that RNA strand is really what is wreaking havoc all around the world. Now, we have that ACE2 receptor in various parts of our body. I know we're programmed into thinking that, it's a respiratory virus, and when we see people on TV, we witness them in the ICU, or we see them being intubated and having breathing challenges. However, this particular virus can attach onto many various segments of organs in our body. Here on the left, you can see it can attach onto your heart tissue. It can attach onto your gastrointestinal tract, leading to diarrhea symptoms. Of course, in the lung tissue is very prevalent because of the large surface area that we have in the lung. And also we have the ACE2 receptor on our kidneys, and it can potentially lead to kidney injury. And I'll show that more in just a moment. And so I really wanted to help people understand that when we think we're dealing with a flu or a cold virus and people are really kind of wondering, is it real or is it not? The dangerous part of this particular virus is the fact that it can attack many different organ systems in our body and can cause a lot of damage in that regard. And so lately we've been hearing a lot about the variants, and this is occurring because we really have not been successful in shutting down the transmission of the virus from one individual to another. Now, it's really important to really understand, back in 2019, the original version of this virus, we call it the wild type virus, is what we call a zoonotic virus. It jumped from animals and then infected human beings. But over the past year, and now over a year, being transmitted from one human being to another all around the world, this particular virus is now mutating and is creating variants, and I'll show more about that in just a moment. But it's learning the human body now. It's learning to attach onto the human body even better, and it's learning to move and transmit, become more transmissible from one human being to another. And we've been hearing about the different variants that we have here. Of course, the B117 that we hear a great deal about, which is now very closely approaching 50% of all of the infections that are occurring here in this country. And we're very concerned about that. Now, we heard about the P1, which originated down in South America, and the B1351, which originated in South Africa. And it's really important, again, to understand these are variants, and it's not uncommon for a virus to kind of have the variant production. But what is happening right now is that this particular virus has learned the human body, is now attaching much more readily, reproducing even quicker than before, making it much more transmissible than it had been before. And so many people, and this is a very busy slide, scientific slide, and I got permission from a group of researchers up in Washington State, up in the Northwest. But really what I want to show here, people wonder, well, how do you even go about detecting the variant? What is that all about? Well, when we find an infected individual, now we go back and we do a genetic sequence on that particular virus to figure out what's happening with it, what proteins may have changed, and then we can identify the changes in the protein from the older type to now the new type. Here, what you're looking at is what we call the Cal-20 variant that developed out in California, in the Los Angeles area. And we really think it's really what wreaked havoc on the Latinx community and in the Los Angeles County area. But the little yellow dots you find here are representative of the fact that through their research and through genetic sequencing, we can now detect when these variants occur. But not only can we detect that, we can actually figure out what did that variant do to make it more admissible and more likely to travel throughout our body. And here, most of the variants that we've been detecting have been in the spike proteins. So it's really important to understand. I want to just give you an example of how we figure that out. Now, kind of shifting over, for people that have chronic cardiovascular conditions like diabetes or high blood pressure, 2 weeks ago, the World Health Organization came out and notified us that obesity and overweight is a particular condition that we have to be concerned about for people that become infected by SARS-CoV-2. But for individuals that have these conditions, just by virtue of having the medical condition on its own, means that you probably you're likely or potentially have some type of vascular inflammation internal to you, secondary to being diabetic or having high blood pressure. For individuals that have these proteins, these inflammatory proteins, if you were to become infected with the coronavirus, it can actually turn those inflammatory proteins and rev them up in such a way that on the far right, you see you can develop what we call a cytokine storm. And this is when many inflammatory proteins just kind of spin out of control. They're large numbers, and they can actually wind up attacking organs and causing damage. And you can see many of the things here. As you begin to escalate from the left to the right, people would develop fever, cough, fatigue, all of the different things leading to potentially respiratory failure in some individuals. Now, about a year ago, I really began paying attention to the fact that this cardiovascular interplay between the coronavirus and human beings really began to play out right in front of my eyes. And so I went back and I pulled a heat map. And on the left here, you find the prevalence of cardiovascular disease all across the entire country. And then on the far right, you see where many of their initial outbreaks were occurring. And these outbreaks were occurring and really leading to a fairly high death rate in many areas. We had a high death rate occurring up in the New York City area, as we all know. There was an outbreak in Detroit, and then I really paid particular attention to what happened down in New Orleans, having been there for a portion of my life. And if you took the two maps and overlapped them, it was almost predictable that everywhere that we had a large propensity of people that had cardiovascular conditions, that we also had high death rates and infection rates that were occurring. So I just really want to drive home the notion that this is why we as pharmacists, myself, Dr. Hill, and other people, all of our medical community, our nursing community, we really wanted people during the COVID-19 outbreak beginning last year in 2020, we began calling people, and we wanted to try and get those conditions under control as much as possible. We did not want that cytokine storm, and hence the inflammation that can occur from that to spin out of control. Here again, very quickly, I'm just kind of showing all the different areas of the body that can be infected by the coronavirus. Again, we all have heard or even known people that had the neurological conditions of brain fog or a loss of taste and smell. I've already talked a little bit about the acute kidney injury that can occur or the GI problems. But again, beginning in March and April of last year, we began hearing about this clotting that was occurring in patients. It started off in the Philadelphia area, and quickly we had reports coming out of New York City. And it was quickly found that the SARS-CoV-2 virus was really responsible for these clots developing throughout the body. Also, we began hearing about cardiac conditions. Now, people that have respiratory viruses, they can develop a myocarditis, which is inflammation of the heart tissue. But that typically, with a typical flu virus, that would occur in about 1% of individuals. Anywhere from 22 to 35% of individuals that actually get infected with this particular virus, the coronavirus, can actually wind up with myocarditis. So we have to really pay attention to cardiac conditions. And being part of our sports medicine team here at USF, we put cardiac testing on any one of our athletes that became infected. Unfortunately, we didn't have very many overall. So many people feel that, you know, the vaccines were developed very quickly. They feel that we woke up in April of 2020 and a group of scientists walked into the kitchen and started cooking up a brand new vaccine. Well, that's not really true at all. As a matter of fact, I showed you earlier where the original SARS occurred back in 2002. A few years after that, people began developing vaccines against the original SARS at that time. But really, I wanted to kind of share this information with you. And here was a testimony given from an individual, Congressman Foster, that really began talking about the fact that it was during the Obama administration where the investment in some of the current vaccines were really made. Now, we often forget that when President Obama walked into the office, he walked into having to deal with an initial pandemic. That was H1N1, if you all recall. Now, fortunate for many of us, it turned out not to be nearly as deadly as what we're dealing with now. But hence, he did have to deal with that pandemic. And then number two, he during his watch, we had the Ebola pandemic that began to occur over in Africa. And he actually had a fair number of people come from our public health service here in the United States and go over to Africa and try and help them overcome that virus over there before it came here. But it kind of informed him at the time that, you know, we need to do a little bit more in preparation for when these pandemics may come up. So back in 2013, we had an initial amount of investment that came from the Obama administration through BARDA, and then followed by another $125 million investment to develop messenger RNA technology around vaccinations. Now, the whole intention at that time, beginning back in 2013, and maybe even before that, was to have a rapidly deployable vaccine that was found to be safe and effective should we encounter a worldwide pandemic. And to kind of bring that to light even more, I found a speech that President Obama gave, and he gave it in 2014, and he gave it with Dr. Fauci right there by his side. And I'm not going to read this entire portion of the speech, but he said, you know, if and when a new strain of flu crops up 5 years from now or a decade from now, we've made the investment and we're further along to be able to catch it. And so part of that investment was actually building a vaccine platform that could be rapidly deployable and on demand when we needed it. It's also really important to understand, I know many people are, you know, have been really concerned about the fact that, you know, it feels like experimentation. I don't want to be a guinea pig. And myself and Dr. Hill and Dr. Austin, we've heard many people refer to the Tuskegee experiment as to a reason why they don't trust the vaccine and they do not want to receive the vaccine. Well, I wanted to assure all of you right now that number one, here I'm showing Dr. Kizzmekia Corbett, African-American scientist. She helped from the very beginning to develop the current Moderna vaccine that we're now issuing to many people here in the country. Also, we had individuals with the National Medical Association, the National Pharmaceutical Association, and other groups that were providing input and oversight directly with the FDA during the production, the research, and now the administration and delivery of many of the vaccines that are now coming onto the market. And so I just wanted to make sure everybody knew that from the very beginning, we've had African American and other people of color involved in developing the vaccine, oversight of the vaccine, administration of the vaccine. And so we don't want people to be fearful that somehow or another that any return of the Tuskegee experiment could ever occur, ever again. Now we've had a number of vaccines. Each one of the vaccines on here, four of the 5 on here that I show are already being issued around the world. Of course, AstraZeneca is not here in the United States, but over in Europe. Moderna and Pfizer have been approved under emergency use authorization, as has Johnson & Johnson. In full disclosure, I do want to let you know I am also on the investigative team here at USF for Novavax and their COVID vaccine. As I expect it will probably go before the FDA sometime in April. Now, the numbers you see here kind of show the percentage that they published around how effective they were. Another question I'm getting quite a bit is whether or not I can trust, for example, the Johnson & Johnson vaccine if they're only publishing that it happens to be 65% effective versus 95% effective for Moderna or Pfizer. Well, the actual fact of the matter is they have very, very different outcomes of how they were approaching getting to that percentage. And they were done at different times. And I would share with all of you that the Johnson & Johnson one-shot vaccine was actually done down in South Africa and South America during a time that their particular variants were running rampant through those communities. Neither Moderna nor Pfizer had to encounter any of the variants. And so we never will really know, once again, whether or not if the Pfizer or Moderna product during their clinical trials, if they had to encounter the variants, would they still remain at 95%? Maybe, maybe not. We don't know. However, the Johnson & Johnson vaccine has been shown to be very safe, very effective. And the reason they came up with that number is because they had much more stringent criteria for how they were going to determine whether or not a person became infected or not. And so I just wanted to share that information with you. Now, the other question we get quite a bit is, if I get vaccinated, what's going to happen to me? What am I going to feel? What will I experience? Well, just like any other potential vaccine, the number one thing that you may feel could be fatigue. A number of people get a mild headache, and a number of other people may move on to chills and fever. Almost everybody is going to have some level of what we call myalgia or pain at the injection site. Now, of course, Moderna and Pfizer have a two-shot strategy, and the majority of people feel more of the potential adverse effects after the second injection. And again, over here with the one-shot Johnson & Johnson, very same thing. You may feel that. However, we want to let everybody know there is no live virus being injected into anybody, number one. Number two, if you begin to feel anything on here, especially the fatigue and the headache, that's really your body pulling energy from your body to help rev up and manufacture those antibodies to protect you and be ready should you come into contact with the actual coronavirus out in the public. And we want those antibodies there before you get infected. I have other evidence, and just for time's sake, I couldn't show the slide, but we do know that from the time that people become infected until the time that they probably get a full, robust antibody response on their own can be anywhere from 5 to 7 days. But during that incubation time period for the coronavirus, it could be running rampant, especially with the current variants that we're dealing with right now. And so also in the clinical trials, and we have found out, and it's holding up out in the general public, that if you do experience anything on here, typically and usually it will not be more than 24 to 48 hours. Beyond a 48-hour time period, most people say it went away. Other clinical considerations, number one, people want to know, what about pregnancy? We hear on these on social media, on Facebook, and it's running rampant, about possible infertility in women. Well, with each one of our clinical trials, and let me go back and tell you, we had 30,000 people in the Moderna trial, 45,000 people in the Pfizer trial, 40,000 people in Johnson & Johnson, and another 30,000 in the Novavax study. And during that time period, in the very beginning, enrollment in terms of enrollment into the clinical trial, no woman was allowed to be pregnant. If you were pregnant, that became exclusionary for you coming into the trial. However, a number of women, dozens of women, as a matter of fact, after they received their injections, became pregnant. And during the clinical trial, the moment they found out that they were pregnant, the clinical trial team began to monitor those women very closely. And they have found, up to this point, no harm to the mother, no harm to the developing baby whatsoever. Nothing has been reported, and they continue to monitor them. And when you enter into a clinical trial, you're in that clinical trial for a 2-year period. So they will continue to monitor them moving forward. But the most important thing around the infertility question has already been answered. Number one, they became pregnant after becoming vaccinated with the vaccine. So there was no issue around infertility. These medications, these vaccinations do not escape the arm to be able to circulate through the body, to be able to come into contact with anything around reproductive organs that we expect that will cause any damage. People ask me about autoimmune disorders all the time. And we say, yes, we do want people to be vaccinated if you have an autoimmune disorder. And then those people who are immunocompromised, again, there's no live virus, so we don't worry as much about an individual allowing the virus to kind of replicate in their body. There's no virus to replicate inside of the body. And also the CDC has recommendations right now for immunocompromised individuals that if indeed they become infected, well, we have other means to help make sure we try and treat them. And so the recommendations are to receive the vaccine, and if they have other therapies that they're getting, to space it out by about a 2-week period. Also, for people who have already been infected before, we do have a recommendation that 90 days later that they actually receive the vaccine, because of course we want to make sure that they have built a robust antibody to the coronavirus, because when you become infected naturally, depending on how much virus you encounter from the very beginning and the quality of the antibodies you produced in response to that, we want to make sure we kind of normalize that for everybody. And to kind of round the corner here and come to an end, just really want to kind of share with you the disproportionate effect that COVID-19 has had on people of color. Here from about a year ago, we see here that African Americans were disproportionately affected in virtually every state in the United States. You take a look at Louisiana, 1, 2, 3, 4 down here on the left. In Louisiana, African Americans make up 33% of the population, but they made up over 50% of all of the people infected, and a larger percent of people that die from being infected with COVID-19. We found very similar numbers for Latinos all across the country. And it's not because of anything unique or anything about the genetics of being African American or having a Latin descent. However, it began to uncover decades of health disparities and lack of access to proper health care, essential worker status, things of transportation, multi-family units and living in multiple families living under one household, high-rise living. So again, we see that happening from a disproportionate standpoint with African Americans. Early on, African Americans were dying at 3 times the rate of our white counterparts. Here in December, that kind of went down to about 2 times the rate. And most recently, it's now come down to 1.4 times the rate. But I also wanted to kind of make you aware of the fact that our Native Indian population, our indigenous populations, per the number of people that they have per 100,000 people, over the past couple of months, they have been the most affected all across the entire country, as now the virus has fallen into middle America. We're talking North and South Dakota, Wyoming, Idaho, Oklahoma. Those middle states that we have right there in the middle, of course, have much larger populations around our white counterparts, far less African Americans. And that's why we've seen that rate come down. But overall, we still find that we're out distancing our white counterparts. And then just wanted to kind of have a revelation here for all of you to think about. Again, here in the state of Florida, we've had about almost 4.5 million people now vaccinated. Of that 4.5 million, 3 million have fallen to the white or Caucasian category. And what we have documented is about 277,000 people that are Black. Now, it's really important to understand that this unknown category, I've been talking to public health officials all across the entire state. I've talked to our dean of our College of Public Health here at USF, and we have no idea what that unknown category means. And what we may be looking at is another health disparity here. Because I can tell you, and I've had people tell me directly out in the community here, that they did not want to check the box for Black for fear that it may mean that they would not receive the second injection if they checked that box. Now, they had fear that the government or other people would not come back to their area if they found out that there were Blacks that were receiving the vaccine, which of course we would not allow to occur. And then finally, knowing that we were having all of our great friends up in the Tallahassee area, I just wanted to make sure I shared the Leon County data so that you all could see as well where you all stand. Again, 58,500 people are vaccinated, about 33,000, almost 34,000 fall into the white category, and just under 8,000 fall into the black category. It's really important to understand when we talk about our Hispanic counterparts, that gets a little bit trickier because, of course, many of you already know you can actually fall into a race category and an ethnicity category. And so we're not really truly understanding there, but anytime I witness that we have more people in the unknown category than we have in the actual race category, it does make me wonder exactly what may be going on there. So we need to pay more attention to that. And so now, as I bring everything to an end here, I just wanted to remind you that this SARS-CoV-2 can affect many different areas of the body. It's not just a respiratory infection. It can cause multiple organ damages to you. And so, yes, we want you to get protected. We want you to get vaccinated. There's no indicator whatsoever that the vaccine has any long-term effect, any negative long-term effect on anybody. And I can also share with you that especially with the Moderna and the Pfizer mRNA vaccinations, that within hours, I'm talking probably less than 8 hours after you've been injected, your body now breaks down that messenger RNA. It has now told your body what to do. And we want to make sure that you all understand that it has no preservatives and no long-term effect. I wanted to show you all here. I personally got vaccinated. People were asking, you want me to get vaccinated? Are you going to get vaccinated? Yes, I got vaccinated. So I'm going to stop sharing right there and take any questions that you all may have. But thank you very much for your time and attention. And I look forward to a good dialogue with all of you right now. But thank you very much.
Dr. Sneed, another wonderful job, and you certainly dispelled a lot of common myths related to COVID, both infection as well as the vaccination. And so if I had to kind of reflect, what you said is that the vaccine really wasn't made as quick as a lot of people think it was. You kind of clarified that we shouldn't worry about things like fertility or damaging our DNA, and definitely that excuse me, people would not get COVID because they're not getting the live vaccine. So now that we have the J&J vaccine on the market, one of the first things that we have been hearing in these workshops is, can we mix them? If in fact, like you said, there were some that were concerned the government wouldn't come back to that area, they wouldn't be able to get the second shot. Does it matter where they go to get that second shot, or what are your thoughts on that?
For the second, you mean if they get the J&J shot? I'm sorry, you kind of went on. Yeah, say it again.
Yeah. If they get the Pfizer or Moderna shot first, then can they get one of the others for the second shot? Because there have been a lot of concerns about, not only having access, but sometimes people have been sick or hospitalized or having just family emergencies and haven't been available on the day that the second shot was offered.
Well, first of all, if you get either Pfizer or Moderna, you should try the best you can to stick with that same one for your second shot. We do not want you to go and get the Johnson & Johnson shot after that, okay? To be very clear about that. That's number one. Number two, if you happen to miss your date for your second shot, we've provided guidance from the CDC that would indicate that you can probably get it a week or two after that time period and get the very same antibody response you would have gotten had you gotten it on time. So if you miss that one time period, get it as quickly as you can. But we do want people to get the second shot. That's very important. There have been reports coming out, especially from our counterparts over in Israel, that maybe you don't need the second shot, but no, we want people to get the second shot without any doubt whatsoever.
Okay, well, one of our participants commented on the Belgian doctor, Dr. Sharon Brown, commented that Dr. Gert van den Bosch A researcher in Belgium, she thinks, is purporting that the vaccine is harming the immune system, and it's difficult for the body to fight off these new variants. But there's been a lot of contradicting articles, kind of challenging and disputing that argument. And so she wanted you to please speak to the impact on the vaccines, on the variants, and you kind of commented on that, but do you have any additional information you want to add?
Yeah, absolutely. We want to make sure that people understand, number one, well, we began getting reports about a year ago that people can become reinfected with the coronavirus. Now, it's not very common, has not been very common. As a matter of fact, we actually had evidence that people that were infected maybe years ago from the common cold version of coronavirus actually had some level of immunity that we call T-cell immunity that probably helped out a number of people. However, I'm aware of the Belgian physicians or researchers work, and there's no indicator that that is occurring whatsoever in terms of the variants. What we are witnessing more than likely is that if people come into contact with the variant after that fact, that it's attaching on and replicating so quickly that people are becoming infected. But you know what? They're not dying, number one, and the infection tends to be much less than it had been if they had not been vaccinated beforehand. And so I fall into the latter part of that category of saying that I don't find that to be credible. And I will also kind of share with you, and it's really important to understand when we talk about harming the immune system, there's zero evidence of any harm to the immune system whatsoever. As a matter of fact, it's just the opposite. And we have to keep in mind, people have been getting flu vaccinations for years. I mean, for a long period of time, we get it every year. And there's no evidence of anything where the immune system has been damaged by that either. Now, if we get new evidence coming out over time, I'll be more than happy to retract that statement. But no, I don't find it to be credible. And for the other researchers coming out and disputing that, I think they're probably much more accurate than the one that came out initially.
Okay. Thank you. So you commented that the most common side effects from the vaccine typically are related to pain at the injection site, muscle aches and the like, and that Tylenol is all we need. And so Mr. Glenn Brown wanted to know again, why not ibuprofen, to control these side effects, but he just wanted to make sure that it was okay to take Tylenol or ibuprofen. But I know we've been kind of pushing for Tylenol.
Yeah, and to be perfectly honest, and Glenn, it's always my pleasure to see you, my friend. Thank you very much, sir. Always my pleasure, to encounter you. I think it's very important to understand, first of all, when many physicians around the country began telling people don't take ibuprofen. It wasn't bound or because of anything that was from clinical research or clinical trials. It was more along the fact that we're talking about an anti-inflammatory. And they potentially did not want to give people any agent that may blunt the effect of building those antibodies secondary to the vaccine. That's number one. Number two, when they lumped in Tylenol, again, Dr. Hill and I, we're clinical pharmacologists at the core of who we are. Tylenol really and truly does not have the anti-inflammatory property that you find in ibuprofen or naproxen. And so even though they kind of lumped the two together, I never found that to be credible whatsoever. Because if they were concerned about having an anti-inflammatory effect that would be mild at best from ibuprofen, then we're not having any anti-inflammatory effect at 325 milligrams of Tylenol or acetaminophen. And so, just to kind of keep the peace on, now I tell people, if you need to take anything, if you have a headache, or if you have, any pain at the injection site, go ahead and take Tylenol and take it after the fact. Don't take it ahead of time. But it was not based on anything in clinical trials. As a matter of fact, every clinical trial I read in the very beginning last year, actually, they recommended what we call paracetamol, which is the European name for acetaminophen or Tylenol. And they were showing that directly in the clinical trials, and nobody had any blunting of any antibody response. So thank you for that question. But yeah, Dr. Hill is exactly correct. We are recommending Tylenol more than anything else.
So Dr. Henderson had a series of questions, but, and I, again, we're so grateful that 100 Black Men has really helped us share this message. But one of his questions was, how do we get this information to the people who are in denial and have their heads in the sand? And then we had another comment from Paula McDonald saying, particularly our younger individuals who feel they're almost immune to COVID, and we're seeing them on TV, hanging out in some cases and in public places, or we do have a lot of individuals that still refuse to wear masks and things of that nature. So I'll let you start off with, what do we do about these people?
Yeah, Dr. Henderson, thank you very much for that question. Again, I was kind of sharing at an earlier talk when myself and Dr. Austin and Dr. Hill were together. I talked about getting into good trouble. Representative Lewis, he talked about good trouble. There's a publication that has come out recently, and I'm writing an open article about this right now, that indicated that the highest transmission rate that has kept the pandemic going over a period of time has occurred between the age of 20 and 49. Okay, from 20 to 49. And then even within that age group, the group from 35 to 49 have been the highest continual transmitters of the SARS-CoV-2 virus. So, we have to get more of the word out. We have to continue doing talks like what we're doing here. We have to have you all go out and advocate. We're having additional campaigns come out all across the entire country right now. But to be perfectly honest, there's only so much we're going to be able to do. A year ago, when we kind of shut down the entire economy, I think we missed a big opportunity at that time to kind of really shut down that transmission, because we didn't have full buy-in from everybody. And of course, now that we're opening up the economy and having no mask mandates or removal of the mask mandates all across the country, people who are infected that fall into that age group, and you have to keep in mind, that's the age group that is working. They're out in public, they're going to restaurants, they're socializing. And there's still a large number of people in that category left to be infected. That's the one thing that we have to keep in mind. So I think your question is a great one. I think we're all trying to figure out how do we get this information out? I think we're doing everything we can to get the information out. But I'm going to be a little bit more forceful right now in terms of my communication with the scientific community and people I interact with, around saying that we must heed the fact that 20 to 49 is a very dangerous group. And if we don't get the word out to that group, they will be the ones that will continue to allow the potential variants to occur, because we're continuing the transmission from one individual to another. And we don't want that to occur. We don't want to get to the point where a variant will now potentially escape from the effective antibody rate that we're getting with the current vaccines. So I think that's the best way I know to answer that question. We just have to continue to work hard and do talks like what we're doing today.
And Dr. Steen, it's interesting that that's the same age group that we're seeing the largest amount of anxiety and depression and even suicide attempts since the pandemic. And the mental health areas are things that I've been especially paying attention to as well. And so to your point, one of the things that I know Dr. Austin and I, Mr. Green, talk about all the time is a need for us to certainly be aware of generational perceptions and preferences. And so all of us and all of you, have probably never thought that the word Zoom would have the meaning, as important a meaning as it does to or has had over the last year. But what we do find is that the younger individuals who are working can't join a 3:30 webinar all the time, and certainly aren't interested in giving up their evenings. But they also are getting, the way they learn information is so different. And so we're entertaining, things like podcasts and other avenues to try to reach them, in addition to the virtual format that we've been using. Certainly, I'm also involved involved in a couple of projects where our pharmacy students are actually surveying college age students to see exactly where they're getting their information from, you know, and certainly what level of anxiety and depression they're experiencing. And for those that are willing to share, how are they coping and dealing with it? And if we're seeing an increase in use of substances of abuse or a decline in terms of academic performance and things of that nature. So we certainly know that we need to share the message, but one of the things that we encourage all of you to do, all of us have a home, and hopefully you're not going home just to a pet or an animal, but that you have family members that you're talking to. And so we empower you with this information in hopes that you will share with others the message. And certainly as you get email communications or invitations to future workshops, we ask that you would join our groupies, like Dr. Henderson. I think this is your third workshop, Dr. Henderson. So we invite you to become a We Care groupie, because as Dr. Austin will say, we've heard the dean talk about this topic since last May in various forums, and I've joined him and I've given my own, but we are just hungry for information, and certainly good, solid information from someone we trust. And so, you know, Dr. Sneed has mentored and taught all of us very valuable things regarding COVID, the infection, and the vaccine. And so we invite you to continue to learn with us and bring people along with you.
You know, Dr. Hill, let me also, I saw Dr. Henderson had another follow-up question here.
Yes.
Is there such a thing as getting too much vaccine?
Mm-hmm.
Let me just share with all of you, part of the clinical trial process, and it's very important to understand because now we're doing clinical trials in pediatrics, and you may have heard about that. One of the main things that they wind up doing in a phase 1 study is measuring and monitoring the effect of the different dosing schedules to find out what kind of reaction that people are going to have, how much antibody are they going to build, are they going to build too much, not enough. And once they get that part determined, that's when they move on to the phase 2 part of a study. And so when we talk about phase 1, phase 2, and phase 3, the phase 1 really is about trying to figure out what will be the optimal dose and making sure that there's no harm created from a particular dosing schedule. Now Moderna and both Pfizer have gone down from 18 down to 15 and then from 15 down to 12 in terms of their clinical trials. And I found out about 2.5 weeks ago, maybe 3 weeks ago now, that right here at USF, we are going to be an active site for the Moderna pediatric study all the way down to 6 months of age. And so, so again, the first part of it will be figuring out the correct dose so that we don't have an overproduction, that we don't have almost an overdosing of a particular vaccine schedule. And so I think that's a very good question. But what we don't want to occur, and I think this could possibly occur, what we don't want to occur, for example, is someone going and getting the first dose of Pfizer and then getting a full dose of like the Johnson & Johnson. I'm not sure exactly what could happen from that, but I guess you could have an over response of your immune system, and we just don't want that to happen. We stimulate the immune response just enough to give us what we need. We don't want to go overboard, but we also don't want to undershoot the amount that we do so that we don't get enough of the antibodies we need to provide protection. So thank you very much for that question.
And Dr. Sneed, if I could also ask, one of the reasons why most times when you go to get vaccinated, you're probably preparing a couple of weeks out and they're asking various information about your age and zip code and, you know, where you stay and maybe a phone number. And a lot of that is because at least here in the state of Florida, that information is put into a database called Florida Shots that actually tracks, you know, your vaccine. And then you're given a card as well that you should certainly keep with you, because as many of you are thinking about traveling, as Dr. Mobley said, to go visit grandchildren and the like, it may come a point where you have to provide proof, almost as if that vaccination card is a passport of sort. And that's been also talked about. But there are measures to try to make sure that others will know whether or not you got vaccinated. But we don't want you in the midst of everything to feel you need to get every vaccine that comes out, because there's going to be a lot more that'll probably be hitting the market. So we just want to reiterate that. Okay, Mr. O'Neill had a question. What's the name of the screening for myocarditis, Dr. Sneed? He said, especially in athletes, and is the stress test enough?
Yeah, so it's not really a stress test at all directly that we're looking at, not singularly, but depending on what cardiologist or cardiology office you go to, they would be doing an ultrasound. That will be one of the first things that they would do to see if they can detect any type of inflammation of the heart tissue. Now, other studies, more intensive study, can actually go into cardiac MRI. And it's been the cardiac MRI that began about a year ago up at Ohio State. And that's really where we began to find out that anywhere about 33% of all the athletes who have been infected actually did have some level of cardiac involvement secondary to being infected with SARS-CoV-2. But as of right now, and again, I interface with our sports medicine team all the time. I know that we're not doing MRIs on every single individual. That has come under question because, we never really went back and did cardiac MRI testing on people that were infected with the flu. So, we don't know the relative rate of what it might mean to be infected with a common virus, a respiratory virus versus SARS-CoV-2. But the cardiac ultrasound is where we kind of started out here at USF, and it's pretty common all around the country.
And definitely, I want to give kudos to Dr. Sneed, because his work with our athletic program has provided a strategy for our athletes to be tested frequently enough for there to be an assurance that when they're practicing and engaging in sports, that we don't have to worry about the spread of COVID for lack of testing. So the concept of pool testing, was partly his idea, in addition to certainly providing education. So I just wanted to kind of put that in. Another thought came to mind as I looked back over Mrs. McDonald's question, Dr. Sneed, in regards to how to reach the younger people. And as we look at that age bracket of 25 to 49, and they are working individuals, one of the things we've been fortunate enough is to work with some employer groups that are having to make the decision about what are going to be the criterion for people to come back to work or not, or keep their jobs. And so Bank of America has been one group we've worked with. We've worked with another private company called Neogenomics. And again, just empowering the employees more so they can make an intelligent decision about the value of vaccinations. And so I just wanted to add that I think that that's another effective measure. But as, Dr. Sneed said, that becomes a captive audience. So, if it's mandated, or not, but we've had really a good positive response and requests, from individuals who've heard a workshop that may have been in the evening, and then they've reached out and asked us to consider doing something for their work group. So just wanted to kind of add that as well as another mechanism. So Dr. Henderson also asked Dr. Sneed, what's the origin of this myth that the vaccine alters the human DNA? Because I brought that up, I think, also at the beginning.
Yeah, to be perfectly honest, I can't speak to what the origin is. I don't know where it originated. Mm-hmm. However, I really do believe that people, if you're not really a scientist and you don't have a scientific background, the moment you hear RNA, you probably think interchangeable between RNA and DNA. And very early on, Dr. Hill has developed a very robust relationship with a group of Nigerian pharmacists over in Lagos, Nigeria. And she invited me to come and give them a COVID presentation last year. And they had the very same question. It has run rampant on social media that, it can go through and alter DNA. Well, let me share with you, messenger RNA has no involvement whatsoever with your DNA. It doesn't enter DNA. It does not affect DNA. And let me explain to you all in very lay terms with relatable metaphors that you all can relate to. Each one of you is on a computer and you probably have a Word document. And if you type in the word vaccine on a Word document, when you hit enter to send it to a printer, and you tell the printer to print out the word vaccine on a piece of paper, the code that goes from the computer to the printer, the computer message that goes over to the printer is analogous to exactly what the biological code is to tell the body to print up something that eventually will result in antibodies in your body. We have a little thing called a ribosome, and so inside of our cells, the ribosome is analogous to a printer. And the code comes in and tells the ribosome what type of protein to print up. And when it prints up that protein, it actually then the body responds by building antibodies against the protein that we told it to print. And just like with your computer right now, the moment you hit enter and it prints it out, that code goes away. It doesn't keep on printing vaccine over and over and over and over again. It dispels it, and it's exactly what your body does with the messenger RNA. Many of you probably have never thought about the fact that if you think about the nails on your fingers and how hard that is compared to the cartilage in your ear, messenger RNA help to produce the protein that tells your body what to print and where to print it. So we have all types of RNA in our body that has nothing to do with coming in and altering our DNA. Messenger RNA, it tells our body what to do, and then the body degrades it and gets rid of it. And so I hope that kind of explains a little bit more about the RNA and the DNA alteration. It has no involvement, it has no contact, it does not enter DNA. That's a very complicated portion of our cells as people. And the current vaccine structures are not designed to alter or come into contact with our human DNA whatsoever.
So, Dr. Steen, would you agree? It's evident that health literacy, has been part of our challenge as well with the pandemic, because people hear these terms and because they don't totally understand it, and it gets unfortunately compounded by social media and the like, and everybody kind of, adds on to it as it goes. And so they may confuse DNA and RNA very easily, just simply not understanding the differences and the role, of all of that exciting stuff that we deal with. Yeah.
Well, I'm kind of smiling, and I apologize. I will be a terrible poker player, Dr. Hill. But when we talk about when we talk about medical literacy, to be perfectly honest, the coronavirus really uncovered medical illiteracy even within the medical community.
Exactly.
We have to really keep that in mind. Early on, when we first really began talking about the ACE2 receptor, and I was hearing people talk, I was saying, no, that's not what that means. We have another type of receptor in the body that's very similar to that, but it's not the same one as what we're dealing with the coronavirus. And so, it's been a lot to learn for a lot of people, but you're right. Very often, if medical professionals, many of which are not physicians, if they're having trouble deciphering, then we should not expect many people out in the community to be able to decipher it as well, which is really one of the reasons why, the presentation I give actually is kind of founded in educational theory. And I try and make it as visual as possible and not put up a bunch of words that you can actually interpret and you can actually kind of absorb and then walk away and be able to not only understand, but implement what we talk about. And so I think that's a great question. But yeah, when you talked about that, when you said medical literacy, I said, well, and I don't want to get too specific here, but there are people who are not inside of the mainstream healthcare group of people that we commonly think about, but who are healthcare providers, that they themselves had to really go back and begin to more probably either read up on or better appreciate what, for example, mRNA really is, what it does, what it doesn't do, and that kind of thing. Because I was witnessing online, people were sending me videos and hearing people talk about mRNA, and they were completely wrong. Oh, by the way, in start recognition of Women's Month. Okay, and I think we are still in Women's Month. Okay, I know we had International Women's Day, because I made sure I sent out as many messages around International Women's Day as I could. But here in Women's Month, I wanted to kind of make sure everybody knew that it was a woman that actually discovered messenger RNA and the CRISPR genes and everything else that led to the development of the current vaccine that we're working on right now. And so, you know, there's not, you know, Dr. Henderson, I just wanted to share with you, and this is a discussion point I think we can all have. Right now, if the coronavirus, if it were going around and it were causing an acute cancer, if it were causing cancer, like if you got infected, you got cancer within a month, we would have no problem with people getting the vaccine. Okay, because nobody wants cancer. And if we knew that that the cancer would kill 500,000 people, everybody would say, you know what, I don't want to get cancer. Well, the messenger RNA technology actually began to emanate out from much of the cancer research that we're doing around immunotherapy. And so, you know, people thought, hey, if we can do that over here, we can take that technology and we can apply it this way over here in vaccine development. And so, you know, when I'm hearing about the hesitancy and people not wanting it and not believing in it, I keep thinking, there's not one person I know that if they had cancer, that would not say, you know what, do what you can to save my life. Well, you know, we're kind of in a very similar boat right now. And as far as the 20 to 49 age group and employment, and, you know, I started kind of smiling when you mentioned that, Dr. Hill. You know, I'm not a proponent at this current time of saying that we should mandate that everybody in every employment environment get vaccinated. However, as a legal question, I did go back and inquire from very high level employment professionals. And there are laws on the book that could require people to get vaccinated if they felt their environment would be negatively impacted because of the coronavirus. Now, I don't want us to get there. I want people to make an informed decision. As a matter of fact, I'm not even here to try and convince any of you to do it. We want to inform you. And then hopefully you can make an informed decision yourself to either encourage yourself to go get it or encourage other people around you to go get vaccinated. But yeah, the 20 to 49 age group, that can be a very dangerous situation, especially with the emergence of the variants at the rate that we're finding them right now. So I just wanted to add that part in about the legality. I'm not recommending or saying that people are going to do it, but it is on the legal books right now that it could be required as a condition of employment.
Well, thank you for that. Well, Christy had a question. She said, if you already had COVID a year ago and haven't received any of the vaccines, are there any tests recommended to prove what kind of long-term damage the infection did to the body and or the strength of the antibodies that you have?
Yeah, that's a great question. I'll start with number 2 first. You can actually go get an antibody test. You know, we're going to look for IgG antibodies, and we can figure out, you know, if you have that, and you get a titer test, and it'll kind of tell you if you have it or if you don't, if you have them or if you do not have them. It may not always tell the full story, especially if you've been infected by what we call the wild type virus, because once the virus kind of goes away, your body kind of stops the production of the antibodies. Now, what we have been able to determine is that people who have been vaccinated, they do have active antibodies up to a year later. The people who originally got antibodies a year ago, they still have some semblance of antibodies a year later. And so now, as far as the first part of your question in terms of damage to the body, well, that would be through normal testing. So for example, you know, there will be different what we call a comprehensive metabolic panel, a CMP. Well, I think that would be an initial test to figure out if you had any kidney damage that would develop. But after that, it's all going to be symptomatic. We're going to look for symptoms, and we're going to let your body tell us that there's a problem. Right now, I have known people that were infected last April that have yet to regain their smell and or taste. Okay, and they're in their 30s. And so I worry, what if they don't ever recover that? You know, the younger people, we have a level of invincibility, but I have now encountered a number of people who a year later are still having lingering problems. I have another young man, well, he's not my patient, but he's affiliated with one of my patients. He was a top performer in his company, a rising star, just doing very well, considered very bright, became infected, wasn't that sick to begin with. But after he began testing negative and was ready to come back to work, the brain fog hit so severely. He cannot function at that job anymore. And last time I talked to my patient about that individual, he was considering going on disability because he can't function. The brain fog is just too severe for him to be able to have function. And so I really didn't know if that qualified for disability. That's how it even came up. I said, I don't know if that qualifies for disability or not. But we do know that there can be long-term and lingering overall effects, but more than likely there will be symptomatology that will go along with that, and not simply like a test that we will look for to see if you had organ damage.
So
Yeah, great question.
Yeah, and most of what feedback we get is typically subjective, in regards to what people are experiencing. As you talk to them, you get different things. Now, Mrs. Andre also kind of confirmed, a myth that I mentioned earlier, kind of going back to our discussion about the RNA and DNA, and just kind of clarified, that vaccines don't actually enter the nucleus or the heart of the cell. And so it doesn't change or modify, how the cell actually works. But unfortunately, that's another myth, that's being put out there, that the vaccines are actually doing that. So one of the things,
Dr. Hill, let me add on to that very quickly for this group, because I had a pretty high level. Now I had one of these scientific conversations with a colleague that wouldn't be appropriate here because the terminology just got way out of control. But my question was, once you get injected in the arm, and you begin to have antibodies and some of the proteins that develop from that, whether or not even that could escape into the circulatory system at all. And then what we determined is that no, it doesn't, because it remains in what we call interstitial tissue right there at the site of the injection. And so even that does not escape into the body. And so knowing that, it just seems that there's very, very limited information or data or evidence whatsoever to indicate that that anything about the antibodies. Number one, there's no preservatives in any of the current vaccines. There are no preservatives in any of the vaccines. That's number one. Number two, we have no evidence whatsoever that it would encounter any interaction with any of the reproductive organs in women whatsoever. And as I mentioned before, during the clinical trials, women became pregnant after being vaccinated. Dozens of women, not just a few, with no harm to the woman or to the developing fetus. And so I think it's very important to really kind of get through, even though it's getting around very quickly, that the messenger RNA has no capability of interacting with DNA or entering into other cells in your body.
Okay. I apologize. Thank you, Dr. Sneed. So Dr. Henderson asked the notice that we were recording the session and how could we get it? And so in the chat, Dr. Austin actually put a link to ReachUp's YouTube site. So if you would like to share this with someone, please feel free to do that. And you will also find other recordings from other previous programs, one of which that we're also proud of outside of the range of COVID per se, was a workshop that we did a month or so ago addressing the Tuskegee experiment and the Henrietta Lacks story. So we would encourage you to also appreciate some of the information on that. But we do have several of our workshops related to this topic and others. So please check that out. We've had a few individuals that unfortunately had to leave us, but we do hope that they enjoyed it, and wanted to also say, Dr. Sneed, you setting us up. Dr. Henderson wants to know if we're going to get a vaccine that's going to cure cancer.
Hey, well, you know what, Dr. Henderson, let me just share some really good news with you. but it's not because of the vaccine, not because of what we're encountering right now. Remember, everything that's happening right now, we planned for 8 years ago. Because the whole idea, and oh, Dr. Henderson, this is a great topic. And it kind of came up in a different way, but I want to share with you because very quickly, I anticipate that you're going to begin hearing, if you haven't already heard, about potential booster shots. So the magical part of what we have done with these current vaccines is that once we get the genetic sequence of the virus, we take that and then we go and we can directly build almost a synthetic vaccine platform that 100% matches up to that portion of the protein of that virus. And so we can tailor a vaccine directly to that particular virus in a particular portion of the virus. So in this case, we built a vaccine that is genetically identical to the antibodies we want to attack those spike proteins. So now the variants, what is beginning to occur? The variants, now the proteins on the spike protein are changing a little bit. And there are 3 main portions of the spike protein. 2 of the 3 have remained intact, but a third one is where a lot of the mutations are beginning to occur. And that's why the currently available vaccines, they can still attach on to the other 2 and give you protection. Now, in the future, if we get more mutation, or if next year, if it mutates and we need to change it around, as long as we can get the genetic sequence, we can 100% match up the vaccine to that particular virus. And we can do that within a 3-week period. Within 3 weeks, we can already know exactly what the vaccine is. So rapid deployment of the current vaccines was the intention. Now, going back to what I said earlier, we are developing vaccines for cancer. We can call them different things, but immunotherapy is actually a very high level component of now chemotherapy for cancer, where we can get the genetic sequence of the particular cancer. We can put that into a platform that can actually then get nanoparticles and other things and other portions of the immune system to then go right back in and attack only that cancer. And so that's where this immunotherapy that we hear about for cancer is actually becoming very prevalent and very promising. Also, and Dr. Hill, I think you probably already know this. You knew it before I did because I know you. But we very promising results from another clinical study are coming out around vaccines for Alzheimer's. And where we can actually get, we're now building vaccine development that can actually attack the tau proteins, the tangle proteins in the brain that lead to people getting Alzheimer's. So yeah, you're exactly right. It's a very exciting time, to be in this world because we know a lot of people who have been affected by Alzheimer's. We know people affected by cancer, and we're witnessing the effects of the pandemic. At the core of that is cell and molecular biology that we're understanding at a much higher level than we ever did before, and we're being able to generate and produce the therapies at a much higher rate and much cheaper than we ever did before. There was a therapy for immunotherapy that was costing $1 million 2 or 3 years ago for people with a certain type of cancer. I don't know the current cost right now, but I knew even back then, I said, well, that's going to come down pretty rapidly and quickly. So thank you very much for that question, Dr. Henderson. I really appreciate that. Allow me to kind of expand a little bit more for this audience that we have here.
And that really is important because as we're focusing on the pandemic, life is still happening to us in other dimensions. And all of us probably know people that also have cancer or are unfortunately having to deal with trying to treated and things of that nature. So I think we're kind of narrowing down on our questions. So just want to remind you, if you have any more questions, please put them in the chat. I want to thank Mrs. Andre for sharing, that unfortunately it wasn't fun for her to have to deal with, some of the residual effects from from being infected. So brain fog, getting tired, and all of that affects how much we can work. Certainly the loss of hearing from the middle ear inflammation, for months afterwards. And I know I have both family members as well as neighbors who shared the same story. So there's a lot of evidence that the virus definitely gets in the brain, and it takes a while to get out because there's this like mesh-like apparatus that really protects the brain, and most times things can't get in. But this virus, as we've said so much, is so smart, it just kind of cheats and gets into the brain anyway. And so we're seeing a lot of residual effects from COVID once people are infected. So we do have one more question. Maribel Rodalis, I hope I didn't mispronounce the name, and I'm not sure if she's even still on now, but she asked, after being vaccinated, would your COVID rapid test show positive, or does it need to be the antibody test only?
Yeah, so the rapid test would not show positive. The only thing that you would be able to detect after that would be an antibody test. But no, a rapid test would not become positive after being vaccinated at all.
Yes.
Yeah, and I want to add on one more thing, back to Christy Andre's, her just kind of sharing with us her experience. I just want to share with all of you again very quickly. I shared it earlier today, so I know Dr. Hill and Dr. Austin heard it already, but again, in my actual clinical practice, I treat a lot of diabetic patients, and I had a patient come in a month ago, came in with a family member, and the family member was on oxygen and had been infected, and told me at the time that they were going to be on permanent oxygen. This week on Tuesday, that the patient came back to see me without the family member. And I inquired about the family member, how are they doing? And unexpectedly, she shared that they had been told late last week that she was only going to have 3 to 5 years to live now, because she had such significant lung scarring from the COVID-19 and from the inflammation that resulted. She would probably, the only way that she would be able to live would be to get a double lung transplant, and she's not eligible, or was told at the time that she was not eligible for that to occur. And that was a very, so I had, we both took a moment just so she could kind of gather herself, and it really affected me. And so, the one thing, the very final thing I often tell people is, we need to take the opportunity right now to live. I had to, I had to change the way I said this, because we were dealing with so many clergy and so many faith-based groups. But initially I was saying, the devil that we have right in front of us is far more dangerous than the devil that we don't know about maybe 3 to 5 years from now. But of course I wanted to change that around. So now I say the danger that we have right in front of us is far worse than the danger of our fear in our mind of what could happen to us 3 to 5 years from now. This is a deadly virus, and it's affecting people in a very, very bad way. And we have found a solution. And I know people are trying to figure out, well, do I want to do it? Do I want to take a chance? What will it do to me 5 years from now? But if you get infected today, we have no guarantee that you're going to walk through it and not be unaffected. And you might acquire permanent damage. And I'm really concerned about the people who have had acute kidney injury, because one thing about the kidney, and by the way, the kidney, without a doubt in my mind, the second smartest organ in the body behind the brain. And the kidney has a lot of resilience, but when it goes under attack, we often wonder if maybe 3 to 5 years from now, or 10 years down the road, if we have removed some of the resilience of that kidney because of the injury it incurred right now this year in 2020 and now 2021. We don't have an answer for that. I don't have an answer for it. We're not going to know that for a period of years. But we are going to have to continue to monitor and watch out for that. And so, yes, I'm encouraging people to get vaccinated. This vaccine, the virus is mutating, is learning the human body at a much higher rate than we anticipated. I was watching the news 2 weeks ago with one of the top virologists in the country. And even I was amazed that he was amazed at how quickly in just a year's time that the virus has been able to adapt to the human body and still cause the amount of damage to people that it's doing. Typically over time, the damage will go down, or the virulence, we call it, will kind of begin to decrease, because the virus is trying to make an attempt to live. And that's how we wound up with the common cold. You know, at one point in time, the common cold probably was a killer for human beings. Now we get the common cold, we don't even think about it anymore. We say, oh my gosh, I got a cold, I'm gonna be indisposed for 2 or 3 days. Well, we kind of expect that the coronavirus would do the very same thing, but when the B117 came out from the UK, and now we're finding that the mortality has not gone down from that, it's probably ticked up a little bit. Well, that's completely unexpected for this particular virus. And so I just want to encourage people to go out, get vaccinated, continue to wear a mask, continue to social distance. We will get back to normal in the not so far future, but until then, we have to do everything we can to protect ourselves. So Dr. Hill, I just wanted to end with that, just in case we don't have any other further questions.
Well, I did have a comment that in regards to the testing, I know a lot of people are traveling or considering traveling more. And a lot of times if you're going out of the country, they'll ask you to get the rapid test, but they want to see an antibody test as well. And, you know, the CDC is definitely reminding people as well with the vaccines that they may in fact cause a false positive antibody test. So you need to communicate. You know, if you get vaccinated, you need to communicate if you're planning to travel, if you have been traveling. And all of this, as states are opening up more, you know, definitely you don't want to certainly invest your money and be in a situation where you can't get refunded and things of that nature because of the outcomes of these kind of tests. But we certainly want to thank you, Dr. Sneed, for again sharing your insight. We thank all of you for attending, and we really hope that you found the time spent with us very valuable. We definitely thank you, Dr. Henderson and the 100 Black Men of Tallahassee, for finding it, you know, an important topic for us to, for you all to consider co-hosting and working with our group. We really, really appreciate that. We're forever grateful to Dr. Austin and Reach Up for always being there for us and setting up the technology, managing the registrations, and then certainly providing us an opportunity again to hold their hand as we reach out to the community to try to make a difference. And so Dr. Sneed said it already, but I have to repeat it. Just make sure that whether you get vaccinated or not, you still remember and understand the importance of following the CDC guidelines. And who knows that maybe this time next year, you know, the pandemic won't be limiting our lives as we know it, particularly from the socialization aspect. But right now, while we're in this public health crisis, everybody be safe. Be safe, please. And just know, and we have put information in the chat. I provided my email if you wanted to reach out to me. Again, we invite you to look at the YouTube channel so that if you want to see this or other recordings put on by We Care, we invite you to do that. And we do hope that we see you in future workshops. So we'll allow Dr. Henderson to have the last parting words, and then we'll let everyone get on with the rest of their evening.
Thank you so much, Dr. Hill, Dr. Sneed, and all of your cohorts there. I am very much enlightened and encouraged by this outstanding presentation. That's why I just wanted to be sure that we had a vehicle or some kind of a way to get this out to the community. This is far too valuable. This information is far too valuable for just us to consume it and keep it to ourselves. And I think that if people were to hear this, in particular, that group, that age group 20 to 49, if they could hear this, unfortunately they're working, I understand that, but I think that if they heard this, we would at least get a percentage of those people to buy in and go ahead and get themselves vaccinated and otherwise follow CDC guidelines for social distancing and wearing a mask. So this is just valuable information, and it was done so well. I really appreciated it. It was right so I could grab it. It's like low-hanging fruit for me, and I'm sure that if I can understand it, I know everybody else can as well. So, but thank you so much to you, Dr. Hill and Dr. Sneed and the University of South Florida, and all of the other folks who participated in this outstanding presentation and event. I am indebted in the 100 Black Men of Tallahassee Area, Inc., and I'm sure the greater Tallahassee, the greater 100 men, Black Men of America really appreciates your efforts in trying to look out for the common good and what's good for our community. So thank you so much. And I look forward to seeing this on our social media and other places. Thank you.
Thank you. Thank you for the opportunity.
Thank you. Will everyone